Good evening, Dr. Medina. My name is Jennifer Champon. This week's soup note, I happen to have interest in working on endocrinology in for my signature assignments. So yesterday, I happened to meet a first-time patient to the clinic who is a female Hispanic. The name is Am, and the date of birth is 6/15/1983. Happened to be a 42-year-old female. Came to the clinic unaccompanied, complaining with the problem that she'd been experiencing for the past months. The chief complaint was, I am tired and gaining weight. Even she does not eat much. Even I am not eating much. So I did the HPI on her, complaining about being cold, being fatigued, weight gain, constipation, and then this has been ongoing. The fatigue is the one that bothers her much, but rest improve it or make it better, but still she still felt tired. She denies anxiety, diarrhea, she denies palpitation, she denies tremors, and then she does not have any history of any thyroid problem. There was no acute distress, and then perform things okay, but she has to take a break in between of her activities. She only take medication, which is multivitamins, and she is not allergic to anything. She also is obesity, and then she also has hyperlipidemia, but she's not taking any medication for it. She's a wife, a mother of three, and living with a husband with no complaints about home violence or anything. She feels safe. She does drink occasionally, does not smoke, and she's a very spiritual person as well. She exercises, she walks, she do everything. She have a good sleep, but still she feel tired after the number of hours that she's sleeping. She's a high school teacher, and then thinking that maybe she does too much at school, so thinking that that is the cause of it. She's safe at home in the marriage, no domestic violence or anything that she's been experiencing. We get to the raws in terms of the questions. She said that she reports she's fatigued and then gaining weight, that the weight it's not something that she intentionally eating as much or maybe taking medications that will cause her having that increase of gaining weight. All the system was all denied. GI was the one that she also complaining constipation. She's having normal urination, no blood in the urine. The integumentary was also reported. She was having a dry skin, a thin hair on her arm and then her legs. Neurology, she was all intact. Endocrine, whereby she reported she was feeling fatigue and weight gaining and cold intolerances. She also denied any polydipsia or the 3Ps, and there's no tremors. Weight gain, she had 198 as her weight. Temperature, vital signs were all within the number of range. So as we continue, her face was like a little bit mild, pre-orbital puffy when I kind of saw her, and then stating that she kind of like felt that there is some kind a lumps or nodule, but she seemed that around her throat it seemed enlarged. So we decided to do a lab work, do the thyroid stimulating hormones, and then the T4 we found out that it was, as a result came at the end of the visiting, we found out that it was elevated. So we happened to do the system. I happened to conduct the system on her. The system also, she was having fatigue in the presence of talking to us. Her hand also was cold, even that we have to give her a blanket. The room temperature was normal, but she was feeling a little bit cold while that she was in there. The assessment, the other systems, the cardiorespiratory, GU, and neurologic, and the other system was all within normal. She denied everything with all the system, but the one that I kind of find it obvious was the puffy face that she was having. We did a thyroid testing whereby I felt a little bit enlarged on her, and then there was no tenderness or maybe any nodule around the thyroid area. She was swallowing fine when I did the thyroid test on her. She swallowed good, but I felt like it was a little enlarged. All right. And then the skin also was observed, was like a little thin hair on the arms and then the leg. And she kind of told me like she was losing hair as well. So we look into the hair. There was no dent or anything, but it looks like some patches was losing hair. So as my diagnosis came along with completing with the assessment, I primarily gave hypothyroidism based on the evidence practiced by Wilson. All the complaints that she was having, all the assessments that I conducted on her proved to me that yes, she is experiencing hypothyroidism. The second diagnosis that also clicked on mine was major depressive disorder. That also come along with fatigue and then the persistence of low or mood swings, but she was not even having no suicidal ideations. And then there was no severe based on the evidence-based practice that I researched on. The third section also diagnosis also was Cushing syndrome. So I kind of ruled that Cushing syndrome out because the patient was not having severe hypertension or any severe hyperglycemic, and then she wasn't even taking any medications. That also is kind of like hyper cortical zone. We kind of find also that there was no thin arm or legs, no stretch marks on the body, or neither the around, like having a mood face, which is the round face that the Cushing syndrome people that has. So we kind of rule it out. So our primary diagnosis was hypothyroidism based on the evidence-based practice that I researched on and I came out with. What is the plan? The plan and then the diagnosed labs that we also receive in terms of the lab work help and then also supports our diagnosis. I also decided to give a medication for the treatment as Synthroid levothyroidism, which is 50 milligrams, which my preceptor also agreed on it. And then we decided that in case like we call her back to do a follow-up and then we still need to be titrated, we will be increasing it from maybe 12.5 to 25 milligrams. So, having been said, we give an education that also will allow her knowing that this disease, or maybe what she is experiencing, it will be a long lifetime treatment. So she has to be compliant to with her medications, taking the medications thoroughly on an empty stomach, and then not to take any medication with it, and it has to give some time, about 30 to 60 minutes after taking those medications, and not to cause the medication not to be absorbed in the system. So when it came to the follow-up, we plan to let her know that she has to come back the next 6 to 8 weeks, so we can reassess her, and then knowing the level of the thyroid, so we will keep eye on her. We also advise her that in case she's feeling any severe palpitations, chest pains, or anything that seems abnormal and then does not sit with her body right, she has to rush herself to emergency, in a sense of trying to avoid any thyroid storm. When it comes to the reflection part, I use American Family Physician Thyroidism Guideline to guide me through my assessment, and then to able to support my differential diagnosis on MACE-AM. According to the approach that I have with my preceptor, and then the systemic lifestyle that she also has to learn, and then has to make the changes of, in terms of her background as Hispanic, and then knowing about the metabolic risk that it can also develop, to prevent all of that. When it comes to the Gene Watson creativity factors, I use the factor 4 by developing a helping, trusting, human caring relationship through empathy, listening, and providing education to her. I also use the creativity factor number 7 to promote interpersonal education and learning by guiding the patient to calibrate in with her lifelong approach to manage the Hashimoto diseases, which is the hypothyroidism. Why this case is so meaningful to me, because I also happen to have a family member who is hypothyroidism, and when the it get very severe with the cold, no matter how room temperature that we increase it, no matter how heavy blankets we provide, get very tired, we have to support her and all. So that is why this topic is really meaningful to me. Thank you so much, and I hope that everything in my presentation went successfully. It took a little longer of the time, but thank you. I appreciate having you, Dr. Medina, for this term. Have a good night. Bye-bye.